Good evening, all. First, on today's World Preeclampsia Day, I want to thank all the faculties, the panelists, and the registered delegates who've joined to discuss the critical importance of preeclampsia. At the outset, I would want to congratulate and thank all the chapters of fetal medicine who've taken efforts to reach out to their community to spread the awareness of preeclampsia in the ways of news articles, television snippets, all that they could do. And we do appreciate the efforts taken because we have to ensure that collectively uh, all the stakeholders that participate in the mother's pregnancy journey, we are responsible to diagnose the preeclampsia early so that we can effectively manage preeclampsia before it sets in. So, to discuss the uh, complete perspective of preeclampsia, I would like to call Dr. Ashok Khurana and would like to share his thoughts on the new thoughts, new processes about preeclampsia. And then we would go on to the panel discussion, which will be conducted by Dr. Chinmay, and she will take on with all the practical perspectives that we face in clinical practice. So over to you, sir. I welcome Dr. Ashok Khurana, the Professor Emeritus of Society of Fetal Medicine. He's been the founder, father, and the whole and soul of SFM, and we are all because of him. Over to you, sir.
Thank you, Mohit. Thank you for that very moving introduction. I'll take a second to share my screen and we shall go ahead with the first part of the evening. We did decide that we will do this in two parts because one should be on what is new and one should be on what is standard and how we should be doing it. And so thank you for this opportunity. Over the next 20 minutes, I will take you through what is new in the field because it's very important. And I'm so glad that we as a society observe World Preeclampsia Day. We've been spreading awareness this whole month because it's also World Preeclampsia Awareness Month. The whole of May is Awareness Month. And also because we are shocked actually with the statistics that are coming in from all over the country. We've known that the 2 to 4% incidence of preeclampsia that we find all over the world does not apply to India. And we thought it was 5, maybe 10. And some districts then started reporting as high an incidence as 27%. Now, if you look at the recent data in the last 2 years that we've come across, both in our own Journal of Fetal Medicine and otherwise, it's about 13 to 16% in most areas, which is very disturbing. It does mean that 1 out of every 6 patients will have preeclampsia, and that is something we have to attack because you're familiar with all of this, that there is about 76,000 mothers who die every year and 500,000 babies each year who actually suffer because of preeclampsia. And that's only the deaths. The morbidity is a huger amount. Of course, even in terms of growth restriction, about 1 in 6 growth restricted babies is restricted because of preeclampsia. And what's worst is that when the mother leaves the actual comfort zone of her delivery place, she actually is still prone over the next 6 weeks for the risk of gestational hypertensive disorders and needs to be very careful. We also understand that we have reached a stage where we can act early, screen early, and as put forward by the Preeclampsia Foundation this year, predict, prevent, and prevail, so that no family should face early delivery due to preeclampsia, because we have this really inexpensive answer to prevent most of preeclampsia, aspirin, low dose. And we will, of course, discuss that in my talk as well as in further talks. And so I will take you through new thoughts, products, and processes for preeclampsia, what is widely accepted, of course, in brief. Most importantly, the placenta in pregnancy, we think of it as the villain, but is it really the villain or is it the victim of a maternal cardiovascular disturbance, which of course then gives us the actual new realm of the 4th trimester of pregnancy, which is post-pregnancy disease, starting with preeclampsia and moving on to much more serious stuff over the next so many years. I will talk also about ophthalmic artery Doppler and the manner in which we can do surveillance of preeclampsia in terms of new products and protocols. Because you see the statistics in the lower part of my page here. The number of years lost in terms of a woman's life and the number of days lost to disability thanks to this disease is huge, especially in low and middle income countries, and we cannot afford that. And therefore, we have to offer solutions. Luckily for us, we moved on to, in most parts of the world, to being able to screen for preeclampsia using the FMF rules, which is maternal characteristics, mean arterial pressure, uterine artery Doppler, and biochemistry with PLGF. And we are able to go way ahead of just a clinical assessment by maternal characteristics, because the ACOG guidelines would help you to detect the older ones. Now, thank God we have newer ones, would help you to detect only 5%. The NICE guidelines would put you in charge of about 39%. And this scheme of the Fetal Medicine Foundation now lets us detect like 100% of the early onset preeclampsias, which is the really serious stuff. Also, because at the same time, we have an answer. And that is very simple. That look, if you give 2.4 mg per kg of low-dose aspirin at the right time, which is nighttime, and you make sure that the patient actually has it, that the woman who is pregnant has it, then we will be able to actually prevent preeclampsia. And what aspirin does is to push the onset of preeclampsia by several weeks. So if she were to ordinarily get a preeclampsia starting at 28 weeks, this would now manifest only at 36 weeks, which really is the difference between morbidity and mortality and a good life. And even the term preeclampsia shifts so that the whole incidence goes down. Also, that it is such an inexpensive alternative and everything goes right because we have a personalized risk estimate for the entire obstetric population, including the nulliparous ones, in the first trimester. And typically, there is a 99% certainty that preeclampsia will not occur in screen-negative women. The low-dose aspirin can be started at the right time here. Excuse me, and early institution of aspirin improves perinatal outcome. And you know how much more common it is compared to Down syndrome, for which we spend half our lives. Down syndrome is 1 in 800. Preeclampsia, like I said, is 15% of pregnancies today. And what we're able to then push forward is a better statistic to the government to say that we need a first trimester preeclampsia screening program, on which we then will piggyback the Down syndrome, on which we will piggyback our anomalies evaluation. And therefore, this is what I'm trying to use with the government, the powers that be in Delhi, that we should start allowing or insisting on first trimester evaluation, just like we did several years ago for the second trimester evaluation. Now, we know that it works when we use all this combination. And the question I always ask is, sir, this is expensive. What do we do? It is not expensive. We have a lopsided concept of how we spend our money. Yes, there are certain very poor people, and there might be very, very few only of those. You must encourage them to come along and create schemes for them. But the vast majority would go and spend 25 times that money in a single evening of refreshments and celebration. And therefore, we will not compromise. Because if, for instance, you want to use PLGF, your detection rate goes down to like 70, 80, 85%. That is just not good enough. And that effect arises here. If you don't use the rest of the stuff and use only biochemistry, again, that's no good. And if you use the whole algorithm, you're doing a pretty good job of detecting somewhere close to 100% in all the recent data. And that's how it should be working, with mean arterial pressure, uterine artery Doppler, PAPI and PLGF, and look at how much you can detect. So there's no question of trying to compromise and saying, I will only do this. That is something that we will discuss as we go along. But the good news is that, yes, we have the Hypertension Society, which has given us guidelines in 2021. We have also the ACOG biomarker guidelines, which have come up this year. the ACOG practice bulletin in 2020, the NICE guidelines of 2023, the Canadian guidelines from 2022, and of course the FIGO guidelines, which were a little earlier, but are still pretty much valid. And they've helped us not only understand the condition a lot better, but also clearly indicated that we need to encourage first trimester evaluation and intervention. And these will, of course, be discussed in the panel discussion that follows. What I want to put forth at this time is that we must realize that this has been one of the most dangerous, what you see on the screen now has been one of the most dangerous recommendations that have ever come across from FIGO, because the way the bureaucracy works in our part of the world, we tend to look at a side where we can avoid responsibility. For the sake of feeling better in our conscience, FIGO recommended that in developing countries, in low and middle income countries, we will not necessarily use uterine artery Doppler, and we will not use PLGF. That isn't good enough, because there is no reason to believe that the Indian woman should not receive the kind of respect or care that should be given to any woman all over the world. After all, what has the Indian woman done wrong to deserve this second-class treatment? It makes no sense. And therefore, I suggest that we reject this part of the FIGO guidelines, and like I always say, we do a complete evaluation to the extent possible. There are some interesting criteria that have come across from organization Gestosis, which now is largely India-based, and there is Gestosis score. But again, if you present this anywhere and government gets a hand on this, they firmly believe that they will not need anything more than this. They never look at the fine print because it doesn't suit them. At any rate, when you look at this, if you have a slightly obese nulliparous woman, she's going to have enough of a minus score, which means that virtually every girl who has polycystic ovaries, which is half the northern Indian population, will be on low-dose aspirin. It makes no sense. You can't do that. You can have exsanguinating hemorrhage from this, and therefore you have to be careful. And therefore the new thing is that you and me will not emphasize these things because they undermine the rights of the Indian woman. Moving on, we have understood for many years now that there's a first wave of trophoblastic invasion into the spiral arteries at about 8 to 10 weeks, a second wave at 16 to 18 weeks, and this entire conversion of the wall of the vessels in the spiral arteries from endothelium to trophoblast is completed by about 24 weeks, so that each one of these vessels becomes less tortuous, much larger, and is able to meet the demands of pregnancy. That's the physiological basis, and this does not happen in a bad placenta. And because of these vessels remaining like they're pretty much similar in the non-pregnant phase, or just a little bit of opening out, that is when trouble starts, and that is why we get abnormal placentation. This abnormal trophoblastic invasion results in placental ischemia, endothelial activation, and we now understand this completely, which results in two things: a vasoconstriction and a microthrombosis, which results in not just preeclampsia, but is also the basis of disease and growth restriction, abruption, HELP syndrome, and stillbirths. And therefore, we need to sort this out. And it's become pretty easy to sort out because we understand that each section now has a very, very clear equivalent in terms of biochemistry. The first stage is decreased uterine artery flow, a low PAPE and a low PLGF. Then when there is vascular compromise and endothelial activation from the ischemia, you find a rising SFLT, which is anti-angiogenic, and a low PLGF, which is angiogenic, and therefore that creates the worst possible environment for appropriate functioning of the placenta. And then, of course, there is end organ damage, which will be discussed further in the panel discussion. What we are happy to note is that we no longer have to wait till we are much older and the disease is actually manifest, that is after 20 weeks, but that as early as 12 weeks of gestation, we're able to identify this, correct it, and completely change the course of that pregnancy. And this validation has come over in the past few years, and we're very happy that yes, this new information is going to carry us through. We've also realized that you cannot say that just because somebody is doing well in the kindergarten section of the school, that they will go on to Harvard Law School. Of course not. And therefore, we changed the dependence of models from the old logistic regression models to accepting the fact that the placental ischemia will change as the disease advances, as pregnancy advances, and therefore we will need a model where we can add all the competing risks, which means for every risk factor, there would be an additional or a different outcome. And for every positive factor, there would be a different outcome. And therefore, this will act later in pregnancy, which means that the story does not end at 12 weeks. This means that the story ends only several weeks after birth, when we are beyond those 6 weeks after 40 weeks. And that is where the story ends. And throughout this, we need to do surveillance. And we will try and understand that over the next 10-15 minutes. And of course, in the panel that follows. So what we've learned is that at 12 weeks, we need to do mean arterial pressure, uterine artery and PLGF. At the time of the anomaly scan, my apologies for jumping that slide. At the time of the anomaly scan, we need to jump to add on SFLT and PLGF and always repeat the uterine artery PI. At 32 weeks in the West is when they have decided that they will also repeat this in the high-risk group, and definitely at 36 weeks. How do we modify this in India? We know that our incidence of growth restriction is high, which means that all of our patients fall into the high risk for growth restriction and therefore should have an additional ultrasound scan at about 30 weeks. And therefore, we will shift the 32-week window and add a window at 30 weeks. And we will discuss how this works from a practical viewpoint. We did realize from the prognosis study that when we add on the element of the ratio of the SFLT1 and the PLGF, then we're able to identify many more of those women who will develop a problem in the next 1 week and those that will develop a problem in the next 4 weeks. And let us see how this works. At 12 weeks, we're able to get a high-risk group, which you put on low-dose aspirin, and you have a low-risk group, which don't receive aspirin. The low-risk group will come back to you at the time of the anomaly scan, where you will definitely do a Doppler of the uterine arteries, and in addition, add on SFLT and PLGF, and then reclassify them into a low, intermediate, or a high risk. The low risk will just come back at 36 weeks, except in India, they will now come back at 30 weeks. The intermediate risk will then be reviewed at 30 weeks, which is where most of our patients will fall. And if it's a high risk, then we need a clinical assessment of blood pressure, proteinuria, and home BP monitoring from 24 to 31 weeks. There is, of course, the group led by Stefan Velornen, which suggests that you go by the actual ratio of SFLT and PLGF. And if it's less than 38, they just move into a low risk and they go on for standard surveillance. If it is somewhere between 38 and 85, that's an intermediate risk, and we will increase their surveillance. And if it's more than 85, then they have a very high level of surveillance. Remember that if the SFLT PLGF ratio is less than 38, progression within 1 week is unlikely. And if it is greater than 38, progression within 4 weeks is likely. Not necessarily a predictor of severe eclampsia or severe preeclampsia, sorry, but definitely a predictor of something serious going to be happening soon. And that is the kind of information that you and me are looking for. So that was why we stand today at your basic screening and your surveillance. But a lot of patients will come in your outpatients, unbooked, swollen, and with all kinds of disturbances in their blood and urine evaluation. And you want to know whether there is something wrong, which is related to preeclampsia or not. The useful test that has been developed here is something which is called the Congo Red test, which binds to misfolded proteins. And then it's been commercialized to a plate, which gives you a design, which is like this. And based on the appearance of this design, it quantitates you in trying to detect severe eclampsia as well as mild cases. And it's not perfectly accurate, I understand, but it's a great test to use for unbooked cases out in the periphery where you don't really have any other method of detecting these. And this is going to be commercially available pretty soon. The validation tests have already been done. Is there something else? Yes, there is another product, and this is called glycosylated fibronectin, and this is a protein biomarker. And those that have an elevated glycosylated fibronectin have a high risk of preeclampsia. And you can see that red curve compared to the green, which is a normal curve. And you can see it's operational all the way from 13 weeks onwards to 40 weeks. Now, it involves a finger prick blood sample, and you put that onto a little plate, pretty much like a urine HCG plate. The results are available in 10 minutes. It has all the approvals in place, and it's semi-quantitative, which means that if the results are green, it's less than 250, and there's a negligible risk of preeclampsia with a very high negative predictive value, which is valid for 4 weeks. If it is yellow, it's mild to developing preeclampsia with a repeat testing after 2 weeks. And if it is amber, it usually indicates about 351 to 600 level of the actual fibronectin, and there's a high risk of preeclampsia with a very high positive predictive value of 98% for preeclampsia within the next few days. A high positive means that you have to actually consider imminent delivery, and that shows up as red. And this is something that is already commercially available. Looking at some more things, can we predict all of this before 11 weeks? And the answer is no. We cannot try and do that. It doesn't work. And we should not try and do that because it doesn't work. And therefore, we still have to wait later. But what we can do is to try and replace some of this stuff that we actually do at this stage of pregnancy with a new technique called ophthalmic artery Doppler. We're still working on ophthalmic artery Doppler for the 12-week window, but when we look at it at the 35 to 37 weeks gestational age window, in the conventional screening bit, we do realize that when we use uterine artery PI with ophthalmic artery Doppler, we can actually double the rate of detection of this particular condition, which is term preeclampsia, very easily. Also, we understand that it seems to be working pretty well when you use it correctly, which is the PSV1 to the PSV2 ratio, which I will show you in a few minutes. It's also been tried in the earlier part of pregnancy, which means at the time of the anomaly scan. And in this particular situation, we realize that using it along with mean arterial pressure jumps the detection rate of just maternal factors alone from 56 to 80%. And if you combine it with mean arterial pressure, the actual detection rate jumps from 69 to 83%. And in this situation, you, of course, can add on the PLG and SFLT, but you can see that you're actually getting like an 83% detection rate, which is really a fantastic detection rate. It's a very easily accessible vessel for Doppler assessment. The patient's eyes are closed. She doesn't need to remove her makeup. You use a superficial pulse transducer of anything between 9 and 15 megahertz frequency, and we realized that there is a change in the impedance and flow velocity waveforms in the ophthalmic artery. It's the only vessel that you will actually see there, and you see that little thing as a little green vessel there, and the mother is to be supine, and you reassure her. There's a preset for this, which is shown here for those who want to know the details. But more importantly than that, the kind of flow velocity waveform shows a sudden peak, which is the first systole, then a second systole, a notch at the beginning of diastole, and continuous forward flow at the end of the cycle. How do you quantify this? We don't use the PI. No, we don't use just the first PSV, the peak systolic velocity. We don't use just the second peak systolic velocity. We actually use the ratio of the second peak systolic velocity divided by the first peak systolic velocity. And ideally, you should be taking 2 readings from each eye, and that's when you seem to get the best results. And of course, there are norms that are now available on the internet, and you can use those. But most importantly, you realize that it remarkably changes everything, even if you don't have biochemistry available. And you know that ultrasound is relatively inexpensive compared to biochemistry. So perhaps for our Indian population, this is where the answer seems to lie. We do need the equipment, of course, and we do need the expertise, and the rest of it will fall into place. What else is new? We do understand that there is now a change in realizing that truly the placenta is a victim of abnormal maternal cardiovascular status. And this is some excellent work that has been done by several groups, and proponent for this really is Bhaskar, who has shown us that a lot of the cardiovascular indices in term eclampsia compared to preterm eclampsia are obviously different when you do a maternal echocardiography. And when you do that, we do understand, and all of this has been summarized beautifully in the article written by Tilgnathan in Hypertension, March 2019, that the heart in preeclampsia and beyond is not an ordinary heart. Before pregnancy, we need to straighten out obesity, diabetes, renal disease, lipid profile, etc. There are changes in early pregnancy which help the mother to cope. And if that doesn't work out, that is when the placenta doesn't work right. So the placenta is a bystander to actually what is happening in the maternal system, and not the real cause. Is just one of the steps. And then, of course, this placenta will continue to misbehave in the postpartum period because the heart is not coping correctly. And for a period of 5 to 10 years, the mother will have a risk for cardiovascular disease. And then, of course, beyond 10 years of her pregnancy, she will go in for a reduced life expectancy, and of course, cardiovascular dysfunction, which started in pregnancy, will get worse. And this is the reason why a lot of people feel that there is a cardiovascular placental access, which then also contributes to cerebral vascular and chronic kidney disease, and also contributes to all the manifestations of preeclampsia, and of course to fetal growth restriction and stillbirth. And you do realize that a lot of the underlying factors are pretty much the same. What does this imply? It implies very simply that we must look after maternal cardiovascular health before maternal becomes maternal. Every woman should be assessed for this particular thing, and her risk should be minimized so that then these women will not have this risk for placental disease, and therefore there will be a much lower situation in terms of preeclampsia. I'm not going to summarize anything so far, but I would like to thank you for your attention so far, because a lot of this will be continued in the panel that we are going to be seeing after this. And we've kept plenty of time for questions after that, and I look forward to that panel. But before we go on to the panel, as Dr. Mohit Shah announced, we've had a huge enthusiasm for professional awareness of preeclampsia. We've had a huge enthusiasm in our regional chapters for patient awareness, and we've had excellent reports coming from Jaipur, from Jodhpur, from Guntur, from Mangalore, from Delhi, and a huge amount of press releases from Delhi as well. And most importantly, we now have a monograph of all that we're going to be discussed today. We decided, and this was beautifully taken forward by Dr. Rima and by Dr. Mohit Shah, and the Kerala regional chapter has come up with an excellent monograph that we're going to release now. And if I can ask Vishal to share on his screen a cover of this monograph, it is entirely everything that we're going to discuss today. So you will have this information in an electronic form, and you will also have this kind of information because we're going to release this particular edition of this webinar very soon on YouTube, so it will always be there. And truly speaking, then you will be able to go through definitions like we're going to discuss, the daily management, the outcomes, how to manage the patient after she's pregnant, the so-called 4th-trimester pregnancy, and so on. And there's a list of almost 54 references that you can actually deal with and go deeply into them if you wish. I think they're having difficulty getting this on. I think, Alok, were you included as yet as co-host or not yet? And it's an e-monograph, and there it is. from the Society of Fetal Medicine Kerala chapter in their monthly bulletin called Fetoverse. It's called Preeclampsia Screening the First Trimester, Deterrent Action Before the Lightning Strikes. That's the theme. And everybody in that chapter has helped to put this together. And so that's where we stand at the moment. And thank you, Kerala, for having taken this forward. And thanks to all the other chapters. I forgot to mention Bengal, who've had a lot of awareness programs throughout this month. And so now over to the panel. And before we go to the panel, a little interruption from our trade partner. And then I will ask Dr. Chinmay Rath to take over the panel with her panelists. Thank you very much. Atul, can we have so over to Chinmay for the panel.
Thank you. Thank you very much, sir. At the outset, it is really a very good initiative from SFM to have an entire program on preeclampsia, because, you know, when you think of fetal medicine, you're only thinking of the fetus, and that's how people think. We become very myopic and we keep looking at things what are inside the womb. But we also have come to realize that the mother and the fetus are completely inseparable. Until there is fetal medicine, there is maternal medicine, which is relevant to the fetus also. And preeclampsia is one such condition. We don't know whether it originates from the placenta or it originates in the mother, but we definitely know that it affects both the mother and the fetus. And therefore, after that brilliant overview that we got from Professor Khurana, we need to understand that it is going to be something that is going to be considered in everyday practice by anybody who is a maternal fetal medicine specialist. And I have with me a whole eminent panel of extremely illustrious experts here. We have good wishes from Dr. Jaideep Tang, president of FOXI. I acknowledge that we've been very supportive of this program, but he's in South Korea for the AOFOG and its related events. So we may or may not have him right now online. Dr. Mohit Shah is the president of the Society of Fetal Medicine and a very active participant in all academic activities of SFM, currently practicing in Mumbai. Dr. Kamal Gujral, a very senior obstetrician gynecologist with special interest in fetal medicine from Delhi. Dr. Sita Rammurthy from Kolkata. Dr. Shweta Singh from Bhubaneswar, AIMS. Dr. Vandana Bansal from Mumbai. And Dr. Aparna Sharma from Delhi, AIMS. So they are all experts in their own right, and they will tell us things that we have to consider in preeclampsia in day-to-day practice. It's very simple, actually, considering things in day-to-day practice, and a topic as common as preeclampsia, which we've started learning about ever since we did medicine. But, you know, when you actually think of it and somebody says, please make a panel on this topic on a day that is the Preeclampsia Awareness Day, my first question was, where do I start? Because there are so many things about preeclampsia, and wherever you start, you don't know whether you will complete the loop or not. So we decided to start from the very beginning. And today is World Preeclampsia Day. It has a theme of predict, prevent, and prevail. Mohit sir, when we are in the need for direction, we look up to our seniors, and I would ask you here, suppose you had to ask us, how do we start a discussion on everyday considerations of preeclampsia? What would be your advice? Where do we start? Dr. Mohit, we need you unmuted. That's something which happens very often when you're dealing with preeclampsia. You're looking for help and help doesn't come exactly on time. So I would move on to Dr. Aparna Sharma. Would you want to tell us how to start?
Yes, so we start where the pregnancy starts. So we start in the first trimester, and whenever, or probably we should start when the pregnancy planning starts. So generally, when we have a patient and hypertensive disorders in pregnancy, so I think when we have to think about it, we should think preeclampsia. You know, we have this very favorite saying from the point of obstetricians or from the point of fetal medicine specialists that preeclampsia should be there in our minds as soon as a pregnant woman walks into our clinic, or even a preconceptional time. So detailed history should be taken. So the screening for the mother for the possibility of preeclampsia should start when the planning for pregnancy is there. So because this is a spectrum of disorders, it's not just, that's why we call it like the hypertensive disorders in pregnancy, right? So, and this is like we typically, when we teach our students, we say that, we have a spectrum of hypertensive disorders, which constitutes like 5 disorders, which starts with gestational hypertension. It would constitute preeclampsia, eclampsia, chronic hypertension, and chronic hypertension superimposed on preeclampsia superimposed on chronic hypertension.
Do you think we need to define preeclampsia as a distinct entity out of these hypertensive disorders of pregnancy, or do you want to define it as a preeclampsia separately? Is there a role for it, and if it is, what is preeclampsia?
Yes. So essentially, when we want to define preeclampsia, we have to have 2 distinct criteria, that a hypertensive disorder which has started, hypertension which has started after 20 weeks of gestation pregnancy. Any hypertension before 20 weeks would classify it as chronic hypertension. And secondly, typically we have defined it as hypertension with proteinuria. But now we say that even without proteinuria, if there are other signs of severity, which are defined by 5 end organ damage, then in that case, even then we should think of it as preeclampsia. And why it is important is that it has a more bearing in terms of maternal and fetal affection. So it's important to define preeclampsia over and above chronic hypertension.
So Mohit sir, do we have you online now? I think he was there. I don't know. There's some problem with his connectivity, but I think Dr. Aparna, you've given us a very good way to start, where we look at the definitions and realize that this is important. And wherever we consider maternal morbidity in pregnancy, preeclampsia has to be something on top of the list. But things have changed in the way we have looked at preeclampsia. I mean, like I said, from our MBBS days, we've been reading this, and I sometimes used to say it's like corruption in politics, or it's like some scams, which we will never stop talking about. Every time we look at it, there will be something new, but the baseline would remain the same. Dr. Shweta, do you think things have changed in the way we define preeclampsia, and what has been the difference between the old and the new concept?
Okay, thank you, madam. I hope I'm audible. So
Yes, yes,
a lot of work is going on, and a lot has actually changed. Now, the slide that you see, this is what is the older concept, that which all the obstetricians are familiar with. We had the preeclampsia, eclampsia syndrome, chronic hypertension, preeclampsia, which was superimposed on chronic hypertension, and finally gestational hypertension. But of late, last couple of years, 4-5 years, the way we defined preeclampsia was also different. But last couple of years, we find that ACOG, even ISSHP, they've changed the definitions. We no longer have these 4 criteria, but you can have hypertensive disorder in pregnancy before 20 weeks, which may be chronic hypertension, like we already know, somebody with an essential hypertension, secondary, say, to pheochromocytoma or any other thing. So you may have it at less than 20 weeks as a chronic hypertension, as a white coat hypertension, which happens when she presents to the hospital, a masked hypertension, which is revealed later on. But after 20 weeks, there are 3 possibilities. One, you have a transient gestational hypertension. Maybe just one reading is high, even they will go on to have, there is an increased chance of developing gestational hypertension. Then there is gestational hypertension, where only gestational hypertension is there and there are no other systemic afflictions. Then we have this preeclampsia, which is the Preeclampsia Awareness Day today. We will have after 20 weeks. It may be de novo, or it may be superimposed on chronic hypertension. So the way we define it today is a persistent hypertension. This is de novo. More than BP, more than equal to 140/90. Any of the above, need not be both, at or after 20 weeks of gestation. And it should be, earlier we had only proteinuria to say that it is preeclampsia, but now systemic diseases have also been, afflictions have also been added. So even if proteinuria is not there, you may have acute kidney injury, liver dysfunction, neurological features. Eclampsia is now taken because the incidence has come down in advanced countries, and where good maternal fetal care is there. So eclampsia is now taken as a neurological feature of preeclampsia, hemolysis, thrombocytopenia, and even one part is from the fetus, which is the fetal growth restriction. So you have hypertension, you have FGR, say at 24 weeks, 28 weeks, you put them as preeclampsia because these are dangerous. Another important shift that has happened is earlier we used to make a lot of difference that this is mild preeclampsia, this is severe preeclampsia, but now ACOG says that do not differentiate because even somebody with a mild preeclampsia can deteriorate very rapidly.
Sure. We'll
Therefore,
come
same
to that,
importance should be
Shweta.
given to her.
Let's start with the definition part of it. So I think we started with Aparna telling us that think of preeclampsia. Whenever you see a pregnant woman and you see morbidity, think of preeclampsia. We came to the fact that hypertension is important, but you also told us that there are many types of hypertension. So every time a woman walks into a obstetric clinic and her blood pressure is higher than what we expect, we don't jump into the diagnosis of preeclampsia, although we think preeclampsia. We classify it into different things depending on the gestational age at we see it, whether it is persistent hypertension or whether it is, something that is crying out preeclampsia by the definition that you've given. So here I'd like to call in Gujral ma'am once that madam, she has mentioned so many things, but every time pregnant woman walks into your clinic, you get your blood pressure checked. In case it is high, do you check it again or you classify it as hypertension right away?
I would check it again after a little bit of rest. White coat hypertension is there. Check it again. Check it myself if my resident has checked it. Check it on the other arm, very, very important, and then take a call. Yeah.
So again, important things brought here because we are talking about day-to-day practice. One common thing that happens is we are all busy and patients come to the OPD after having changed to modes of transport, reaching there, looking for parking space, and they have hypertension for various reasons.
Yeah.
So the moment the woman walks into a clinic, if you take her blood pressure, it is likely high, which might be just a white coat hypertension or some kind of a transient increase because she's fought with the front office person over the bill to be paid or whatever it is. So it makes sense for you to let her rest a little bit and then go ahead and take the blood pressures.
And also see that she's being taken properly, the guidelines, how to take
absolutely
is very,
if
very
they have been taken properly. And so at this moment, let's just run through that also. So how do you take blood pressure in your OPD?
Well, sitting on the chair, comfortable, backrest, legs uncrossed, sleeves not rolled, very common, especially in winters. They roll up the sleeves and then tie the cuff. That's not good. And then cuff size appropriate, old time.
Very practical points, very practical points. Dr. Aparna, you are in a teaching institute. And would you just...
Yeah, I said feel for the pulse. Your systolic should be higher than pulse. Release it very, very slowly, 2 millimeter. Rapid release, you'll just miss it. Then take the quarter of sound, where it just gets muffled, not at stop. That is the way.
Perfect. So, Dr. Aparna, you're in a teaching institute and you deal with residents who come in new every time. What's the common advice you give them how to take blood pressure in the OPD?
So I would mostly agree with that. So the only problem is that it is not usually followed very easily. So I would say...
True, absolutely.
I would say that reinforcement is extremely important. And I would also say that, increasingly, we also say that, we should not just look at systolic, diastolic, try and look at the mean arterial pressure also. Now,
and madam said that if it's increased in one arm, we'll look for the other arm. So do you recommend that we look at both the
both arms should be taken,
both the arms at the same time? So with all the precautions that madam has mentioned and including both the arms.
You said that mean arterial pressure, have a photograph in your OPDs. All the slides they have, women sitting like that, both the cuff on both the arms, and how to take it and have it written in your OPD to the resident, at least learns how to take a mean arterial pressure and then how to calculate it as well.
Yeah, ma'am. And mostly now these kids, they already have an online calculator. So that's not...
So, but at least doesn't matter. They should know how to make the woman sit and take the blood pressure.
Must have both things.
Okay, so we have with us Dr. Nimi Kansal, who's also technical director of the Dr. Lal Path's labs in Delhi. So we are talking about all this blood pressure measurement and everything, and we want to encourage this as part of preeclampsia screening. Dr. Kansal, do you think this is unnecessary? You're a lab person, you can just tell us all about preeclampsia screening by the lab, or do you think all this information is important for you when you do your lab work?
Everyone. All this information definitely, Dr. Chinmay, is important for us because for preeclampsia screening, it's not only biochemical markers, which sir has already highlighted in the presentation that PLGF and PAPE, they are required. But along with that, what we need, the information about mean arterial blood pressure and definitely blood pressure measurement in both the arms, at least 2 readings, both right and left
So
arm.
we have, thank
Yes.
you. We have all state-of-the-art experts here. We have like people who are doing 3-dimensional ultrasound. We have people who are doing
Yeah.
high-tech
Yeah.
modern obstetrics and somebody who's in a extraordinary lab here. The thing is, all of you are now telling us all we should do is take blood pressure properly. So that's one of the first things in everyday practice that we have to remember, that when we are talking of preeclampsia, our first and foremost concentration has to be in taking that blood pressure correctly, because the definition starts with a definition of the blood pressure. And if that has been incorrectly taken, then the whole, whatever the house of cards or something falls flat on our face. Dr. Sita, you've very comfortably come to wherever you are. You told me you can't reach by the time of the panel, but you very much reached here. Thank you so much. Now tell us, this widespread discussion we are having about preeclampsia, what is the burden of disease? Do you think it's good enough to discuss this or waste of our time?
No, thank you for that question and thank you for the opportunity. As we've heard Khurana sir saying that, though the worldwide it says one figure, we in India, we always underestimate things. And even the National Eclampsia Registry says that we are hovering around 13 to 15%. And it's very high figure that we're looking at. A lot of them go undiagnosed, undetected, and they come up with those Bandor symptoms of end organ failure. So definitely it needs to be tackled. And as we said, prevention is better than cure. So when we have the facilities to prevent or even predict these things, we should be doing it. So it definitely warrants discussion and whatever we have at this point to, make it the incidence less with its complications.
And if we are at all preventing preeclampsia, is it only that we are controlling the maternal blood pressure and making things better for the mother, or does it have any widespread effect on the health sector in general?
The 4th trimester of pregnancy, so it starts with in the first trimester, the implications of having preeclampsia. Early preeclampsia has its own problems, late preeclampsia having, growth restriction, and then the mother continuing as an NCD to developing hypertension in the later years of life, and the fetus, if it is growth restricted, also has its implications of having problems later on in adulthood. So it's a cycle that goes on, and I think pregnancy will be the best opportunity to nip it in the bud and prevent this dreaded NCD that goes on for generations.
So a very simple intervention in terms of identifying preeclampsia, addressing it, and trying to mitigate the effects will have long-term impact on not only the mother, but also the fetus and future generations in overall, isn't it? So thank you for this. And Gujral ma'am, do we need to classify? As Shweta had started talking about it, we had just postponed that discussion because first we wanted to establish what is preeclampsia, and now we know that we have a blood pressure parameter. We also have, organ-based parameters on the mother. But when we look at when it is starting in pregnancy, do we classify it in based on the gestational age or by severity or both? And how is it as an obstetrician that your thought process changes when you see preeclampsia at different stages?
Yeah, correct. See, we have to know whether there are any severe, with or without severe features, the way I would like to classify, irrespective of the gestational age. See, a woman comes to me at 34 weeks of pregnancy, she has all the severe features, I rather deliver her and then my job is done. And woman comes early, like early onset, less than 32, and these severe features are there are very serious consequences for her. and more for the fetus also. If I start at 20 weeks, a very high blood pressure with all the severe features, maybe I'm not able to, continue the pregnancy. And maybe time comes when I need to terminate. So my way would be to look at the severe features and look at the gestational age both, and then take a call, how do I manage? And her past obstetric history, etc. Everything has to be taken into account when I manage. This is the way I like to say it.
So,
already told
Dr.
us we were-
Vandana, do you agree with what Dr. Gujral says, or as a maternal fetal medicine person, what strikes you more? Is it the severity of the disease, or is it the gestation age at which it starts, or both are important?
I think both of them are important. One is mild and severe. Yes, earlier we used to not give antihypertensive at mild, but now we are giving even at mild antihypertensive. Whether we need to admit them, not admit them, deliver them, or just monitor them, the severity is definitely important, and especially if we have all the severe factors along with this. But the onset is more important, because if the onset is early onset, that is less than 34 weeks, they are at more risk for both maternal and fetal morbidity. There's more preeclampsia, severe preeclampsia, more of IUGRs are more common, mortality is more, and maternal mortality also more. So this classification which you've put on, early onset less than 34 and late onset, are the ones where maybe the morbidity is less, the trophoblastic invasion is not very bad, so it doesn't cause so much of a problem. And the ones which are more than 37 weeks, anyway, we are not so much worried about. So this less than 34 weeks is the one which we have to predict. These are the ones which we want to prevent also. And these are the ones which cause more morbidity. So I think the weeks is also important, and the severity both.
So in terms of severity, Dr. Aparna, you deal with a lot of high-risk patients in your OPD. Any particular feature out of all these which you would give more emphasis to, or you would be more worried about, or you think that just cannot be neglected?
So I think we have to look at the patient in totality. First of all, any patient who's coming to us, mostly what really happens is, patients who are coming up and suddenly they have an increasing requirement of antihypertensives. Suddenly, that is one alarming feature. Then, of course, you cannot, that typical feature of headache, blurring of vision, epigastric pain, that is another feature that should never be ignored. Then, of course, the abnormal liver function, then you start suspecting HELLP syndrome. So all of these features, they are taken in totality. Another very important feature is when we are giving multiple antihypertensive drugs. That is something that we have to be really careful about, and then they land up in pulmonary edema. Then again, we load them with magnesium sulfate. So that is again a danger sign that we start looking for. So these things, they really become. So that is why when we said, why preeclampsia is so important to be identified. Chronic hypertensive, you give 3 drugs, you give 4 drugs, we are not really so worried as we are for preeclampsia, because in one day, this patient can go from being a controlled patient on preeclampsia to a patient landing up in ICU. And that is why we are so worried. And that is why I really like what Dr. Khurana said, that we really have to not make an excuse and start screening them for preeclampsia and not just waste our lives on aneuploidy screening.
No, we'll come to that. So each screening, it has its own importance there. So while we're getting, we get your point.
And lose lives. People can lose lives in one day when we are talking about severity.
So it's a bad example to give now, but it's something like the clear air turbulence where you suddenly, your elevation comes down from one point to another.
That's what is lightning eclampsia is. That's why it's called eclampsia,
Eclampsia, yeah.
With a lightning speed. So that's what it is. So we have to be extremely careful.
So we need to be very careful, because anything can go wrong at any time. And as you started, when you gave the definition and the impact, that the 5 major organs, considering placenta also as an organ. So you have liver, you have kidney, you have neurology, you have blood, and then you have placenta. So anything affecting all this, and because the final common pathway is both the maternal health and the fetal health, and therefore that can be affected. So all this has to be taken into account. Why I'm stressing on these points is because very often we get very carried away with our screening, but when you go back to the basics, we kind of forget what is preeclampsia, how do we define preeclampsia, when is it that we call it preeclampsia, and when do we start our action on it. So when Dr. Vandana, which pregnant woman is likely to develop preeclampsia? You see a woman in the OPD every day. Which one is likely to develop preeclampsia? How do you pick up the one who is
So there are risk factors which can be high risk factors and moderate risk factors. But the first thing is that anybody, even without a risk factor, can also develop preeclampsia.
There
So
goes the story. So
so every patient needs to be thought of that they could be preeclampsia. So a primigravida itself is high risk, and Asian women itself is at high risk. So all these high risk factors that are given by the ACOG and the NICE guidelines are good, because for students, we need to tell them what are the risk factors, start looking at it. So starting from the history, whether they have a previous history of preeclampsia or IUGR or multiple abortions, chronic hypertension itself, any other comorbidities that they have has to be looked at. And nowadays, IVF is something that is considered as a risk factor. And other than that, all you have already enumerated: multiple pregnancies, obesity is one, and a long interpregnancy interval. So these all are risk factors, but behind that, every patient should be considered as a risk, especially in
So
Asian
here I
women.
want to bring to the notice for all our audience here that, you know, when you are actually enumerating these risk factors, you're also doing a kind of inherent screening, and that is screening by maternal history. So when you take a maternal history, you're actually looking for all these features, and therefore this itself is a screening tool. So if you find any of these risk factors, you're doing a risk-based history-based risk assessment for preeclampsia. Dr. Khurana even alluded to the gestosis score, and these are all different all kinds of regulatory bodies have given us algorithms by which we should screen. The thing is, all the like Figo made that allowance of using the common methods and the ones which don't require a lot of input to do screening, so that you can make it more user friendly and everybody can do it. But the ultimate issue is we need to do things which will give us maximum output. And when we do screening, what is it that we want? We want to detect as many as possible with the least false positives and false negatives. So this is a little picture here which will give you an idea of how it helps to do a multimodal screening, history, mean arterial pressure, and the uterine artery Dopplers, as is expected by the Fetal Medicine Foundation algorithm, versus the NICE guidance, which is very nice, very good, very easily applicable to everybody, and not criticized because it's not costly. But what is the cost that you're paying? You're costing yourself all that. People who are not shaded, the red bars are so much smaller than the blue bars. So all the people who've been missed by the red bars is the cost of not using a protocol which is sturdy. So sometimes you must think of the cost of losing a diagnosis or losing a detection, which is more important than the cost of doing a particular protocol. So while you do preeclampsia screening, this is just a very simple prediction model and a comparison of multimodality screening versus just standard history-based screening. So Dr. Mohit, do we have you back here?
Yes.
Something else? Yes, sir. So please tell us, how should we be screening for preeclampsia now?
When a patient comes to you, she's had previous history of preeclampsia, previous history of IUFD, growth restriction. That's an important parameter that we need to understand. And then, of course, you've been discussing about mean arterial pressure, and I would tend to agree with Aparna. How much ever you would want to refine them, a change in a lab technician actually disrupts the whole process. You go on training the new person all over again. But yes, we do stress upon biochemistry, and I would like to stress upon one point here, that we offer PLGF to everybody who's had a previous history of preeclampsia and to everyone who can afford it. Let me put it that way. So there are people who choose not to do PLGF, unfortunately. But yes, it is our job to offer it, because ultimately it's a multimodal screening approach. Comprehensively, it is going to increase the detection rate and help the patient in the long run. And most importantly, the uterine artery PI, the mean uterine artery PI. This in the first trimester, well, there are certain defined protocols as to how you go about measuring the uterine arteries, taking the right, taking the left.
So
And
what we understand is you're telling us do everything. Whatever is possible, do history, do mean arterial pressures, do biochemistry, and do Doppler, because
right,
like we saw in the previous scan, it's always the multimodality method which gives us
right,
the biggest, the best detection rate, as opposed to something where we are leaving out one or the other. You did mention
Right.
that PLGF is expensive and therefore we may or may not offer
I'm
it
just
to everybody. But we have a lab expert with us, Dr. Nimi. What do you think is the role of biochemical markers? They are all expensive, is what we have heard till now. We will give it only to certain people who can afford it. Are you happy with that, or can you make it easy for us?
Yeah. So thank you, Dr. Chinmay, for asking this. Actually, biochemical markers, PLGF, of course, I would agree that it is expensive. We have been talking to the vendors who actually supply us kits that you make it, because for if we have to use it for screening purpose, it has to be affordable. We are trying our level best, but yes, like it has to come cost effective from the other side. From our side, yes, we'll make our best effort, whatever cost we can reduce. In the past, we have reduced cost for these biocap PLGF especially, so that it can become
So what
affordable.
helps in reducing cost? Is it just that the lab takes a lesser profit margin, or is there a win-win situation
Even if
where you can reduce the cost and still
So
make it user-friendly?
we combine this PLGF because now most of the lab, they are offering PLGF marker along with the dual marker. When combined with PAPE and free beta HCG along with the PLGF marker, then the cost actually comes down. Then the labs are not keeping margin for PLGF. But yes, if it is only PLGF, then even if with the smallest margin, the cost per se, cost to the lab itself is very, very high.
So it makes
That's why
sense to
it's very,
do PLGF as part of your first trimester screening
yes,
armamentarium. So
yes,
you
yes.
add PLGF to your double marker thing and get a
So
good screening for.
they are like even at very marginal cost, the labs are able to offer it.
Does PLGF affect your aneuploidy screening results?
There are publications where PLGF is included in aneuploidy screening, and it improves marginally detection rate for Down syndrome. But not many publications are there where Down's as a routine PLGF is being used as a Down syndrome marker.
But
It's
it
one or
definitely
two.
aids and it improves the
Aids.
screening that
Yes.
you understand.
Yeah, it
So
marginally.
if we do a biomarker based screening test, we still can achieve a good detection rate for preeclampsia. As opposed to aneuploidies, the preeclampsia screening results are actually better with PLGF and PAPE in the first trimester, in combination with mean arterial pressure, uterine artery Dopplers, and the maternal risk factors. So this multimodal screening, which Dr. Mohit was alluding to, will help us get a detection rate of 95% for a false positive rate of 10% for early onset preeclampsia. And we just heard all our experts say that early onset is our problem, because you know the disease very well, but you just don't know how it's going to be and how suddenly it can spiral into a very, very severe form requiring delivery, which will be then a preterm delivery and all the problems. So these angiogenic biomarkers in pregnancy, they can define both maternal and fetal health. So is this biomarker assay related to some pathogenic mechanism of preeclampsia, Dr. Sita? Why do we want to do these biomarkers?
So as we've heard, because of the abnormal placentation that occurs in these women, and the second wave of trophoblastic invasion that doesn't occur, and there is a shift in the anti-angiogenic factors and the and the vascular endothelial factors. So there is a shift, and these are the biomarkers which help us identifying which women are prone. And in fact, there is a recent study which also shows that there is some genetic involvement of this split. So there could be a genetic variation in these women as well. So because of the change in these biomarkers in the physiology that happens because of the abnormal placentation, that is reflected in the biomarkers that we detect, similar to as we do in the aneuploidy screening as well.
So we know that placenta is somewhere in the center of preeclampsia, whether it is the victim or whether it is the, a person causing the assault, we don't know, but we know that placenta is definitely affected in preeclampsia. Whether that's the beginning of the story or that's the endpoint pathway, that is the question that's being debated on. But in the process of placentation, we have factors which cause vasculogenesis and angiogenesis. And for all these things, we need certain biomarkers. Once we've understood the molecular basis of disease, we know that the genes work through certain chemicals at the molecular level, and these are the molecules which are getting affected. And we know endoglin, we know placental growth factor, we know vascular endothelial growth factor, and the S-FLIT. So these are markers which have been studied actually initially in neoplasia, where new vessels are formed and tumors are they grow into bigger proportions. So the study for all these things started with neoplasia, and then it migrated into this placentogenesis realm, and we've understood that there is abnormality at every level. There's an imbalance of angiogenesis here. So it has started to tell us that preeclampsia itself is like a 3-stage disease. Dr. Mohit, do you want to give us some of your views on this, where the whole pathogenesis of preeclampsia is dependent on problems that are happening, and these biochemical changes are reflecting that pathogenesis?
What is the problem with the placenta? We know that there is a inadequate trophoblastic invasion by the spiral arteries, and that builds up the resistance within the placenta. And as a result, you have the S-FLIT, which goes on increasing. The placental growth factor will go on decreasing because it's a placentation problem. You have large areas of ischemia, you have hypoperfusion, and this will actually increase the SFLT1 to a PLGF ratio. And the whole pathogenesis lies in the oxidative damage that the underperfusion causes to the placenta. And that's the basis of early onset growth restriction, because of placenta mediated early onset growth restriction.
So that is why when you see the stage 1 of the disease, that is where the angiogenic factors, their expression is being changed. You don't have that many pro-angiogenic factors. So PLGF is low. And that's why when you look at it in the first trimester, whatever decidual changes are happening, you're picking it up early. So doing a PLGF in the first trimester helps in getting that first idea that things are not going right. Whether we can change or not change is another story. Then comes the second level of problems, where already there is oxidative damage happening, already there is hypoxia and reoxygenation problems happening. And that is when, because of all the problems that happen there, you have a rise in the SFLT. So SFLT becomes a better method of detecting problems when we are later into gestation. You cannot do this early. And finally, when there is preeclampsia, it's very obvious, but we are not here for the obvious. Detecting preeclampsia in the clinics was being done from 200 years back. But now what are we starting to do? We're starting to detect preeclampsia much before the high blood pressure sets in, much before the definition sets in, so that we can delay the process. Dr. Khurana showed us a slide about the competing risks model. And that says that almost every pregnancy will develop preeclampsia if it is left long enough. But suppose it develops preeclampsia at 60 weeks, it's not a clinical problem because the pregnancy will not go up to 60 weeks. So when we do some kind of intervention, we can delay the onset of symptoms, we can delay the onset of disease, and therefore early preeclampsia may become late preeclampsia, which all of us agreed is a better thing to manage than early preeclampsia. So when we are screening, we are also simultaneously looking at methods of possibility of changing the course of disease. So when we are doing this screening, we now understood that these biomarkers are very important. You look at PLGF in first trimester, you look at S-FLIT in second trimester. Are these important? Is the lab important? Dr. Nimi, we've invited you to this session. We'll say that your lab is good. You'll say your lab is good. Is it important that a good lab needs to do this, or anybody can do it? We are a very poor country. We cannot afford good labs. The lab next to my house is very kind to me. It'll do all what I ask them for a much lower cost. Should I go to you, or should I just go there?
So, Dr. Chenmay, to this actually, PLGF is not available with all the vendors. There are only 3 providers of PLGF. So, it's important that the
Why
lab
is that
is
like
there.
that? Why can't
But
everybody do PLG if everybody can do? This is
probably,
democracy.
I would say that the availability of this marker is only with 3, and most of these, when they would like to take FMF accreditation before launching an assay, because that's how number 2, the volumes, because anybody who will invest in developing a marker, bringing a marker, they will see that whether what is the market. So what I have seen that even like we have been doing PLGF for last, like I think 2014 we launched SFLT PLGF ratio and preeclampsia screening till today. I understand that cost is an issue because of which this marker is not taken up. But primarily what I am seeing that because they are not seeing volumes, that is why not many vendors, they are thinking of developing these assays.
So one
Definitely
thing which
a
you are
lab
telling
is
us is
there.
if a lot of us start doing PLGF, the cost is likely to come down.
Yes, it is
Isn't
likely
it?
to
When
come down.
everybody
Yeah,
started buying masks, the cost of the masks came down.
came down.
When
Yes.
nobody was buying masks, it became more expensive. So
Yeah,
there's
yeah.
a supply and demand theory there. That
Demand,
I
yeah.
understand. But you mentioned something about FMF accreditation or
Yeah.
any accreditation. What
Yeah.
is this process of accreditation and how do labs get accredited?
So its lab doesn't get accreditation from FMF because I had approached FMF. They said that for the last 4 years, they have stopped giving FMF accreditation to the lab. The FMF accreditation is given to the reagent vendor because FMF has a particular criteria in which they see how precise the assay is, how reproducible. So they have a set criteria that this should be the CV of the assay when they do. So these the suppliers, they have to do those validation in their house. They have to prove the precision, that is how reproducible every time when they do the assay, how reproducible the value is, what is the accuracy, and what is the detection rate. For the detection rate, there are known samples which are provided to these labs. They have to do those tests and submit data. Like so for aneuploidy screening, I know the FMF has a guideline that they should have minimum detection rate of 60%. So based on the, if the performance done by the vendor, it meets the criteria of FMF, then FMF gives accreditation to those particular vendors.
So
That
what I understand is you are undergoing a process where you're standardizing some methods, you are taking a peer review or a expert
Yeah.
review of whatever are your protocols. And if we follow whatever is happening in a standard lab, we are more, we are safer in saying
Right.
that we have done a test and the results are valid because we are taking very important decisions based on these tests. We
Yes.
are deciding in whom to start medication. We are deciding in whom to consider delivery. So these reagents need to be kept under strict quality control. And we should therefore adhere to labs which are following these criteria. So it's not like one person endorsing a particular lab, but what we are endorsing is a process where the lab should get quality assurance done, and we should be safe because we are using something which is standardized. Thank you so much for that, Dr. Nimi. And then we come to Dopplers. Dr. Mohit had started telling us something about the Dopplers. Dr. Shweta, how do we do uterine artery Dopplers and how do we use it for preeclampsia screening?
So, uterine artery Dopplers, first trimester, you can do it second trimester also, but first trimester, usually we do in a transabdominal scan. And just before the crossing of the uterine artery, there we take the Dopplers. The gate should be 2 mm, and you can because there are other vessels around there, so you need to be very careful which vessel you are measuring. So look at the peak systolic velocity should be more than 60 centimeter per second. Take it off both the sides because it may be different depending on the placentation, and then we calculate the mean of the two.
Okay, so you've also told us of particular protocol and we need to follow that protocol only, or is there any way I can get uterine artery through any I'm friends with uterine artery and it shows me wherever it is, or should I do it in the standard way only?
No, we need to do it in the standard ways. All the, see, including the labs, including the way the FMF says us to do. That is how we, measured it. That is why there is accreditation for these also. And that is why only certain people qualified, trained, and accredited are the ones doing it. So it has to be done properly. Otherwise, the results are false and we are finally doing injustice. So
So
protocols
again,
have to be
whether it
followed.
is history taking, we started with blood pressure measurement. We realized that there also things can go wrong. We had standardized a method because this is everyday practice that we are discussing. So right from taking history to measuring blood pressure to doing the biomarkers or the ultrasound, everything in its own realm has to be done in a standard manner. There has to be a correct checklist for everything, and we should follow that. And uterine arteries, now she said measure right as well as left. One more headache here. Mohit sir, which one is more important? Is the right more important or the left more important?
When you have a placentation which is predominantly to the right, you would have a right artery PI which was lower and the left which was higher. And you should talk about this concept of pre-diastolic notches. So it's important to understand that as we've evolved, we've understood it well, that it is the mean which is more important rather than just relying on one. We take both uterine arteries and then mean it up. And we have to take the lowest PI as the most reproducible one. But the bottom line is you have to add them up. You have to mean it
And
up.
both so don't get worried with one side being high or one side being low. So uterine artery is basically the artery which supplies the uterus, which itself is a very muscular organ. It carries an inherent resistance, and with good placentation, that resistance comes down. So when the resistance comes down, the uterine artery flows will become much more relaxed. So you can see the one on top with good end diastolic flow and the one below with restricted end diastolic flow. So you want every artery to be good end diastolic flow to say that the placentation is happening well. If that doesn't happen well, then it reflects in a poor uterine artery waveform. But both right and left are important. You take the mean of the PI of both the sides and then use that into converting it into multiples of median. Dr. Vandana, this multiple of median again is another concept I don't understand. I mean, already so many problems we have. Then we have now measured both the uterine arteries. What do we do? How do we decide if it's normal or not?
So basically, they are values of mean PI which are defined. So for the first trimester, if you just remember that golden word of 2.6 and higher is going to be high. And for the second trimester, 1.4 or 1.5 is higher. And for the third trimester, 1.1 of mean PI is higher. But moms are important because mom is part of the Gaussian curve and you want to see where it falls onto. So when you're using it in algorithms, you'll have to use a mom only because that will be defined. And as you said that everything is as per the algorithm we need to follow. So this also needs to be followed by these moms. So if it is more than 1.5 mom, it is
But
high.
you are rich, you have a very nice software, you can do it on that. I don't have that software. How do I get moms?
You can still put it online and get the moms from there. So you have it on perinatology.com also. But if you just go to any online website and put moms, you will get it from there. But otherwise, the labs are there. The labs which are really accredited labs, they will convert this PI into moms and use that mom for your risk assessment. So I think that Nimi can also tell that if I
So
give
if you have
PI of
internet, you can have it.
2.6,
Yeah.
and
So
otherwise the
in
labs, if they are good, is good enough for us.
the labs can tell us, or if we have good internet in the era of Netflix, people cannot say they don't have internet. So they can just go online and perinatology.com or even the Fetal Medicine Foundation calculators. You can put in the values of your PI and it will calculate the MOMs for you. So that is one more fort that we have accomplished. So we have done blood pressure, we have done biomarkers, we have done uterine artery Dopplers, and of course, history taking. And this uterine artery Dopplers now correlates to so many problems that we know it's important to do the uterine artery Dopplers in first trimester of pregnancy. And in this inversion of pyramid of antenatal care, the doing of uterine artery Dopplers was very, very important. So having used all these markers now, history, ultrasound, biochemistry, and biophysical, we can get a risk of preeclampsia. So we get a risk of preeclampsia before 34 weeks, before 37 weeks, and before 42 weeks. So Dr. Aparna, why so many different numbers, and how do we interpret them?
So essentially, the question is, how did we come at this risk? And these risks were calculated based on the aspirin trial, which told us that when we combine this modality screening methodology, we arrive at some risk. So it was seen that these risks perform the best for prediction of preterm preeclampsia. So when we use these modalities, we assume that the risk for preeclampsia for the preterm preeclampsia, that is the delivery before 34 weeks, is 1 in 40. And this is the best risk prediction. And this is the time when we should be starting aspirin. I mean, this is the reason for which we should be starting
So
aspirin.
is 1 in 40 the cutoff, or what do you consider as a cutoff to start?
I consider 1 in 100 as the cutoff. So if the risk is more than 1 in 100, I would say I would definitely want to start aspirin.
So if it is more than 1 in 100 at 34 weeks, or if it is 37 weeks or 42 weeks?
No, I would say that if it is more than 100 at 34 weeks, I would definitely start her on aspirin. See, we are not too concerned about the risk of more than 100 at 37 weeks. Why? Because it has been seen that aspirin may not be very effective in prevention of term preeclampsia. So that is something that we need to understand, that the aspirin trial has shown a 60% risk reduction with aspirin for preterm preeclampsia. So I will monitor this patient for development of term preeclampsia, but I might not achieve that benefit by starting her on aspirin. So this is
when we are doing, yeah. So thank you. When we are doing the screening, we are primarily focusing on that group which is at risk of developing early onset preeclampsia, because as we discussed right in the beginning, that is the group which really, takes us by surprise, and we don't want a bad outcome, and there is a method of preventing it for which we have some evidence. So this is a lady where we have done whatever first trimester screening we wanted. We know her age, we know her height, we know her weight, we have all other things in place, and the uterine artery PI is 0.85 MOMs, and the mean arterial pressure is 1.1 MOM. PLGF is very, very low, and now she has a risk for preeclampsia early onset at 1 in 15. So, madam, what next? Gujral, madam, she's G4A3. Yeah, her risk for early onset preeclampsia is 1 in 15.
100%
and she's
start on aspirin.
G4A3. So
Fine.
you will start her on aspirin.
100%.
Now, there was already a question in the chat box about, should we start aspirin after 16 weeks? Does it increase the risk of... we definitely have a reason to start it before 16 weeks.
Yeah,
there was a
100%.
question about, should we start it after 16 weeks? Anybody can take that. Madam, if you want to take the question, that's also fine.
Dr. Khurana did show a slide with, it does matter, it does affect a little bit, not as good as 12, 14 weeks, but there's no harm in starting. We don't have a robust data to say how much difference it would be there, but that slide, I liked what he showed on the thing.
So what sir showed,
weeks as well.
Yes.
Yeah.
So what he showed was that the whole process of placentation goes on to some degree till about 20 to 24 weeks. So up to that time also, there may be some role of giving aspirin, but once the process of placentation is complete, there is very little role of giving aspirin. And that question about whether it increases the risk of abruption, there were some papers where they showed that, but that could be a confounding result, because these are women who are already at risk of preeclampsia. We know preeclampsia causes abruption, and we also know that after 24 weeks, aspirin does not actually affect the course of disease. So maybe that's how the results came, and we don't know for sure.
Safety of aspirin has been done in many trials, large trials. So that
definitely in the, what, Aparna, you want to say something?
I would just say that we just need to be a little cautious about it. Yes, up to 20 weeks, that is fine. But it has been actually shown in a systematic review in 2018 that, in a pretty large amount of data, that if you start aspirin in a higher dose beyond 20 to 24
20 weeks,
gestation.
Yeah.
So there is a slightly increased risk, and the effect is also not very high.
What
That
is
is
the
So
because
high
yes,
risk?
again,
up to 20.
What is the
So-
high risk? 150?
so for us, let's stick to what we know very well.
Yeah.
And what we know very well is if we start before 16 weeks, then there is a definite benefit.
Benefit. Correct.
If we start up to 20 weeks, there is a doubtful
No benefit.
benefit. If we start after 20 weeks, there is
There's no
more
benefit.
chances of harm, and therefore we don't recommend to start after 20. That's not an ideal scenario. In an ideal scenario, we should have seen a woman before 20 weeks and worked her up for the risk of preeclampsia. If we haven't done it, we've anyway missed the boat at some point. So then if you sink, that's just a matter of time. So what madam said is, if she's high risk for preeclampsia, early onset preeclampsia based on the multimodality screening, we start her on 150 milligrams at bedtime, like sir had also suggested in his talk, and carry it on to 36 weeks. Now, the detection rate of this multimodality screening, Dr. Vandana, would you want to come in here just to explain what is this detection rate and how is this risk reduction achieved?
So the detection rate is done by this multimodality method. So one is for preterm preeclampsia, one is for term preeclampsia. So for both of them, the false positive is 10%. That would mean 10% we are additionally picking up preeclampsia risk, although they may not have it, but we are able to pick up 75% of preterm preeclampsia. So this 75 preterm preeclampsia are the ones we are going to give them aspirin. So when we give it in more than 90% of compliance, we are able to reduce this reduction of preeclampsia by 82%. So as Aparna also said, that term preeclampsia, the prediction is also not so good, and the prevention by aspirin is also not so good. So, but we are not so worried about term preeclampsia. We are more worried about the preterm preeclampsia. So the risk that we pick up is 75% for a false positive of 10%. And if we give them aspirin on the dose that we said, 150 milligram to be started before 16 weeks and to continue till 36 weeks, we will be able to reduce the risk of preeclampsia to 82%. That's a huge amount. And I think that is what Dr. Khurana also said, that we can't just do a routine risk factor associated risk prediction. We have to have this 75% rather than that 40% risk prediction by risk factor.
Rather than a population-based medical screening, you want to give her a precision-based medical screening, which is where we are moving from population to precision. So now this lady reached about 29 weeks. She was started on echosprin. At 29 weeks, growth is on 10th centile. And it's a culture in our country to move on and go to your mom's place for delivery. So from Delhi, she now wants to go to some interior place in Chhattisgarh for her delivery. Dr. Aparna, she wants to travel. Will you let her travel? Gujral ma'am, will you let her travel?
No, not to Chhattisgarh.
Not to Chhattisgarh. She comes to
Delhi to
Hyderabad.
Chandigarh, fair enough, but not to Chhattisgarh.
Okay. So Aparna,
Yeah.
can you
Yes.
predict her chances of developing preeclampsia? She wants to go to Chhattisgarh and come back after 2 weeks.
Yes, so I think now we are doing SFLT PLGF on a very, very
So
frequently.
there is the role of SFLT PLGF. Now, there is this big question about when should we do, why should we do? The role is in triaging, because she says she wants to travel and you want to know whether in this 1 week that she's going to travel, she will develop a problem. So there is the role of doing SFLT PLGF. Yes, please explain.
So now you see there is a rule in and a rule out of preeclampsia. So if you are doing an SFLT PLGF ratio, so you can rule out preeclampsia. So we know that SFLT is the bad, angiogenic protein, and PLGF is the good one. So if the PLGF is getting lesser, the ratio is going to get higher, right? So that's as simple as that. So the higher the ratio, the bad it is for the patient. So if the ratio is more than 38, right? So that means that it is on a bad side. So if the ratio is less than 38, I'm very well sure that for the next 1 week, this patient is safe. She's not going to worsen and she can go home quite safely, right? So,
unfortunately, the ratio is 40.
So I will not allow her to go home as of now.
Dr.
Right.
Nimmi, should we repeat the SFLT PLGF in your lab? Do you think it will make a difference?
it should be repeated after a week. And
After a
if
week.
it is-
But this, suppose somebody comes with the first report like this.
Yeah, 40. It should be repeated because
So we
I
should
think
more
repeat
than
it after
I would like
1 week.
1 week, right?
So, but at the outside itself, I will check the lab in which it has been done, whether it is a good lab. And if it is a good lab, then maybe I will take it at the face value. And then maybe, if she's still at the risk of on 1 week, I will repeat it because, of course, the cost factor and everything is there. I would actually try and understand the need to repeat it. Definitely. And of course, for now, I will not advise.
You've advised her not to travel. She listened to you. She waited for 2 weeks. After 2 weeks, her SFLT PLGF was 82 at 32 weeks. Dr. Sita, what do we do now?
It's very, very high now. And obviously above 85, we know between 38 and 85, it's the borderline. But above 85 is very, very high chance of developing severe preeclampsia. So actually the protocol says that they have to admit them, and these women need very close monitoring, intense surveillance, because as Dr. Aparna said, that their sudden deterioration of maternal symptoms and causing end organ problems can be high. So, if not, then you have to closely monitor them, regularly monitor their, this is the case where you would do an LFT, look at the aminases, whether they are altering or not, do a platelet count and, do the bloods, and then do an ultrasound as well, and then see for worsening of symptoms. And if necessary, then, add antihypertensives or do the needful as the clinical situation arises.
So,
And give her steroids also. And steroids.
no, madam, I'm just confused. I have a machine. I can do a Doppler every day. And why do I need to do SFLT PLGF? I mean, it's just a way of making money, isn't it?
I didn't understand. Doppler as in what?
I can do a Doppler every day. I can tell you when to deliver this patient. I can
No,
do
but that's
uterine
not going to
Dopplers. I
tell
can
you
do.
whether the maternal condition is going to worsen or not. This is something which is going to tell that the SFLT is increased so much and the end organ damage is happening there. So that is what is
But I can do all the Dopplers. I can do ophthalmic Doppler. I can do uterine Doppler. I can do fetal Doppler.
But that's the baby, You're looking at the mother also.
So, Dr. Chinmay, I think, can I?
Yes, please. Anybody help me because
Yeah,
I just
yeah.
think that you all
Chalo,
are just
Aparna,
making
you
money
say.
out of doing SFLT PLGF. It's very expensive. We are a very poor country.
So right now, if you see, there are very definite indications to do SFLT PLGF. One is when you have a confusion in the diagnosis of preeclampsia, you are not sure whether it is gestational hypertension or preeclampsia. You are sitting on the fence. Sometimes your urine albumin is borderline. Sometimes your 24 hours you're not doing. So if you want to make a diagnosis of preeclampsia, you're using SFLT PLGF. We just said, if your ratio is more than 38, right? Or in an early onset preeclampsia, a value of more than 85 rules in preeclampsia. In a late onset, a value of more than 110 rules in preeclampsia. So that is the number one.
And not only diagnosis, it's also giving you some guidance regarding what to do.
Yes.
So when it is more than 85, you can take a decision. See, your Doppler may or may not be abnormal by then. But if her SFLT PLGF is more than 85 and she is 33 weeks and she's showing signs of 160, 100, that is where you can start discussing delivery with her before things become really, really bad. Because here, not only the fetus, we are also concerned about the mother. And in the mother, there is no one test which is going to tell you that everything will remain fine. And if she develops liver dysfunction, if she develops hematological dysfunction, if she develops neurological dysfunction, things are going to spiral downwards very, very seriously. And each of them has a serious outcome. So while we concentrate too much at the Dopplers, why I raised this question was this is a constant badgering that we have from various, centers of care that you can do Dopplers. Why are you doing SFLT PLGF? So you can do Doppler, but the Doppler is only useful when you want to know, as of now, how is the hemodynamic status of the fetus. The mother will have some or the other changes, but uterine artery Doppler cannot guide you towards the need for delivery. It will be high even at 12 weeks. You can't terminate a pregnancy at 12 weeks because of uterine artery Doppler. So we have to put things into perspective and understand the role of each and every test here. So this SFLT PLGF ratio comes as a very objective method to diagnose preeclampsia and find out a mode of action after you've diagnosed preeclampsia at
Can,
a particular gestation. Yes.
can I add
Anything?
something here?
Yeah.
No,
Yeah,
Chan-
ma'am.
yeah. 1-2 papers did say that if you have an SFLT PIGF ratio at 655, that is extremely detrimental. You immediately deliver. This is one. Secondly, you have a full Pyers S model where you feed it on an online calculator, all the labs you've done, the patient gestational age, whatever it is, and the online calculator tells you the risk severity, and how severe it is, how soon you should deliver. So that's a very practical method if you don't have SFLT, etc. This is what I wanted to add. Full
Can
Pyres
I
has been
add to this?
validated. Even
Dr.
Delhi
Vandana?
had a lot of studies in
So
Maulana
we
Azad
have done a
and he had done
practical,
that. Sorry?
so we've done
Yeah,
some
Dr. Vandana
practical
wants to say something.
cases. We've done
Yeah.
some practical cases of about 50 cases of S-split PLGF. And what Aparna said, that we've done it in patients who had developed blood pressure, like gestational hypertension. We were not sure whether it is
Yeah.
worsening or not worsening. And all of them, we did an S-split PLGF ratio. So there, when it was more than 85, of all our cases of 50, there were 5 which were more than 85. All of them had either a pulmonary edema or severe preeclampsia, and within a week, they had to be delivered. 3 neonatal deaths, 2 lives. So that was how bad that more than 85 was. And all of them who were less than 38 went on till term. The intermediate risk also, actually, we monitored, but we could take them till term. So this rule in and rule out is what Aparna was saying is what is happening.
Yeah.
If it is less than 38, we are ruling out preeclampsia. They will not worsen. You can monitor them routinely. And those which are more than 85 are the ones which are really worrying, where you need to admit them, monitor them. Don't deliver them only on the basis of this 85. You have to just monitor and see, and they will worsen and they need to be delivered then. And the intermediate
Absolutely.
is something that we need to look at. So
I
this
think that's very clearly put. I really thank our experts for this, because this is really clearly put that, when you rule in and when you rule out and how you move forward with that. Because at some point, all your decisions in preterm deliveries will be questioned. And you need more and more objective evidence to stand your ground, that my decision to deliver at this day, because these children which you will deliver will all be preterm. They will be at risk of a number of health issues as time passes. There will be cost impact on their thing. And if you actually deliver a woman before things get worse, she might not go to that severity where people will understand what you have prevented. And therefore, you need to be very clear in taking that decision based on an objective parameter, and SFLT PLGF gives you that objective parameter. So if it's such a good parameter, why don't we do it in the first trimester? Dr. Nemi, do you recommend doing SFLT PLGF in the first trimester?
So it's in the second trimester after 24 weeks. That's what is the nice guideline, because SFLT PLGF definitely it reduces in the first week, but it's only after the second trimester where SFLT.
Why, Dr. Sita? Why are we waiting till second trimester? Don't you think we
It's
should
not-
do it first trimester?
it is not going to help.
It's not going to be a good predictor of the preeclampsia at that stage, because the anti-angiogenic that happens, when the pathogenesis occurs, the S-split starts increasing much later. So it is not so as you predicted in your 3-step model, the PLGF is the first one to predict, and then the S-split goes up. So initially when you do it, you might not get the right picture then. And so that is when you do it later, the ratio gets altered and you can predict. And another important thing I wanted to add is, when you're doing this ratio, you should not be doing it on routine women also. Should be only doing in women who have the symptoms, who have blood pressure, mild, hypertension, or who have symptoms, and to predict the severity in the next 1 week, which has a good negative predictive value, as we said, or rule in or rule out.
Absolutely. So SFLIT PLGF is not being recommended as a routine screening. It is being recommended in cases where either there's a doubtful diagnosis or you have to make a judgment call on whether you put this patient in ICU, whether you allow this patient to travel, or you have to deliver this patient for whatever reasons there. So this we have already discussed in a fair amount of detail. So a good negative predictive value with a value of less than 38. Within 1 week, the negative predictive value is as good as 99%, and thereafter is about 97 and 94%, which is also very good. And the prediction of adverse outcomes is about 86% in the next 2 weeks, and that's also very good. All our experts have brought this out extremely clearly. So we are quite clear with this aspect. Then comes to the evaluation of preeclampsia. A quick word, because we had to focus so much on screening because we are very, very concerned about the concept of screening. When it comes to evaluation and management, we kind of think that's the maternal medicine forte. But Madam, would you just agree with all these evaluation methods, or do you have something to add to?
No, nothing. Absolutely right.
So as
You may not need Femnogen in the beginning, but the rest is fine.
Exactly.
Femnogen
So
comes
we
first.
decided that there was hypertension, which we evaluated by blood pressure measurement. And then there was these 5 major organ systems which get affected. And their reflection is seen in all these tests that we have listed there. You can take a picture of that and just understand that the placenta, the neurology, the hematology, the liver, and the kidneys there, we have followed that. Then comes the management of preeclampsia. So once a woman is already, you did your SFLIT PLGF, you did everything, and now she is frank preeclampsia. She is admitted as an inpatient. So Dr. Aparna, what are the main concerns?
Yes, so essentially, as has been written, the first thing, of course, becomes the antihypertensives. Our first choice of first line drug is labetalol. We generally start in the dose of 100 milligram TDS, and then we titrate as we go on. Our general principle is that it should be titrated to a medium dose of the drug, and if it is not controlled, we add the second line agent before going to the highest dose of the drug. And when we are adding the 2 antihypertensives, if the dose goes beyond the second dose of the second drug, then we have to really see that it is going towards a severe hypertension with severe features, and we should not go beyond 34 weeks. So we have to see
Is
that.
the number of antihypertensives that you use any reason to decide to deliver?
Usually not. Especially if it is a chronic hypertensive, we might even give 4 antihypertensives. So that's quite usual for us. But generally, if it is just preeclampsia, they are usually controlled by doses of 2 antihypertensives. That is a general rule. If it is requiring a third antihypertensive, we generally have to see what is the problem. I mean, if there is something else in the background.
Thank you.
So
Now
something
we'll
like
just
that,
move to
it should
Dr.
be-
Shweta, because I haven't really asked her from a long time. But Dr. Shweta, you also belong to a teaching institute, and in your experience also, is the number of antihypertensives any parameter for considering delivery?
Yeah, so we use usually up to 3 antihypertensives at the highest dose. So beyond that, we don't add, unlike madam, we don't add the 4th antihypertensive. 3 antihypertensives, maximum dose. If BP is still persisting above 160, 110, we deliver them. If they haven't
So
reached 34
what
weeks,
is
so
important
34
here for
weeks.
everyone to understand is these parameters may be institution-based protocols. And therefore, there is no one standard guideline that if there are 4 antihypertensives, you need to deliver, or if there are 3 antihypertensives, you need to deliver. So you can make your
No, madam,
institution-based
just a little
protocols.
bit of difference, because the whole idea of terminating early is for the maternal outcome. So that we have to keep in mind. Fetus is very
Hello, Dr. Shweta.
in tertiary institutes 4, then we need to deliver them. That importance of when to conduct that delivery, that is very important.
So
Correct. But my point is whether the number of antihypertensives should be an indication for delivery. And we have a little
Yes, I
difference of
think
opinion
3.
here.
3
You
is
think
what
3?
we have
Other
Aparna
in
says
names,
up to
Delhi,
4.
they can do
guidelines.
4,
Vandana,
but
what are you
generally
saying?
it should be 3.
Yeah,
Generally,
Dr.
it should be
Vandana,
Guideline
wait a
also
minute.
says, ACOG guideline also says when expectant management should be stopped is when you are on 3 antihypertensive, and in spite of that, the BP doesn't control. Aparna is speaking about chronic hypertension.
Please,
So chronic
so I
hypertensive, the
clarify
threshold
this.
is
Yes.
higher.
In
And so
With
there
2.5
probably
I
is
said I said for preeclampsia, for more than 2 also, we really think when we have to add 3.
Yeah.
So for
Correct.
chronic
that is
hypertension,
only for chronic hypertensive, what she's saying 4.
yes.
But for all, the guidelines says that you cannot increase more than 3. If it is still not improving with that, that is the time that you
So
need to.
if your diagnosis is certain and you've started antihypertensives for the first time in pregnancy after 20 weeks with a confirmed diagnosis of preeclampsia, in that case, as you reach 3 antihypertensives, you start wondering whether it is worthwhile continuing the pregnancy
Yeah,
or
one
considering
important
delivery.
thing is that we need to differentiate whether it is chronic hypertension or preeclampsia. Chronic hypertension will have only the elevation in blood pressure. Other systemic effects, LFTs, RFTs, fundoscopy, etc., would not be changing much. So that is why we need to understand whether it is preeclampsia or it is chronic hypertension, which would be present even before 20 weeks.
Yeah,
So
but
I
when
think
you
the message is
take
clear that if the
antihypertensive,
diagnosis is, so yes, Dr. Sita.
yeah, what I was saying is that if you're adding antihypertensives, in these chronic hypertensive people, you can have superimposed preeclampsia also. So
Yeah.
that also makes a difference when you're titrating the antihypertensives. And when you're giving them, it should be the full dose before you start off with the next set of antihypertensives. That is also important.
So if it is pure preeclampsia and we know that we are going up to 3 antihypertensives, and that is the time when you will think. So Dr. Aparna, is that one of the reasons where you will go and do an S-split PLGF and decide the time of delivery, or you'll just go for the time of delivery based on the maternal symptoms?
Yes, so S-split PLGF, no, I would say that, in these cases, first of all, I would actually wait for the control of the blood pressure, maternal symptoms, investigations, the fetal parameters. So I think all of them have to be taken in totality. So
Because here already she's having symptoms of severe preeclampsia. So you're actually now treating it, not looking for reasons to suspect preeclampsia.
yeah. So here, so I generally, if it is preeclampsia with severe features, generally beyond 34 weeks, we have to think of delivery. So generally, we try and prolong these pregnancies up to 34 weeks by a balanced control of the blood pressure, giving her antenatal corticosteroids, timing magnesium sulfate if required, and then planning the delivery in a manner and with a good fetal monitoring.
So Gujral ma'am, this is your forte here, maternal management. What are your words of wisdom after we've listened to all this?
Well, inpatient management, most certainly. ICU setting, most certainly. Pulse ox should be there. They can go into pulmonary edema. A very practical tip that you must monitor the oxygen.
My video is
Hypertension.
not working.
Sorry? My voice is not heard?
No. Shweta's video is not working.
Fine.
We'll
Right. So I said hypertension control, Aparna has highlighted 2 or 3. It is an institutional protocol, maximum doses. Idea is that we maintain a blood pressure 90, 100, not beyond 100. Diastolic cannot be on 160. I'm not saying you get down to 80 always, but that is. And along with that, search for signs, symptoms, what we've already teach everybody and you already said. At every BP visit, that is most important. And whenever you check the BP, ask for these signs and symptoms. Looking at the labs, very important, and that's all about it. And fetal condition, we said, we have NSTs, we have Dopplers, etc. And try this expectant management till about 34 weeks. When you look at the data, by this expectant management, less than 5% would develop complications. And you are prolonging for about 7 to 10 days, a weight gain of 100, 200, 300 grams, and you're giving maturity to the baby. This is what I would say. Carry on
and at
to
the same time,
part.
you're mindful of all the complications that can
Yes,
happen.
absolutely.
And you intervene
very,
before.
very intense monitoring, SDU setting, as I already said, not to be left alone like
So
that.
just like we started with the first slide of where to start, where to finish is also a very big dilemma in preeclampsia.
And
because
then again, your own NICU survivals. You should have your own NICU survivals, not go by the Western standards or your standards. If I have a good survival at 33 plus 3 or so, I may not wait for 4-5 days to reach 34, that cutoff.
And there is the red herring that the best thing that you can do for NICU problems is to do an in utero transfer. But severe preeclampsia is one of those conditions where you where,
Yeah.
where you are doubtful about the in utero transfer also, because even transferring this woman to a long distance in any other method is also a danger that you have to take. So you have
Yeah.
to balance n number of
Yeah.
things.
And
And
your
this
own
is where,
survival rates. I always emphasize that my own survival
agreed,
rate.
agreed.
If I'm
But
comfortable at
suppose there is a
33,
better NICU like 200 kilometers away. Shifting a patient with severe
it's not,
preeclampsia with these things is also a
it's
major
not
challenge.
easy,
So
not easy.
therefore, again, you know, you have to just balance so many things at that
Correct.
front and keep on counseling them. Use multimodality counseling at that point, and use your anesthetist, use your neonatologist and everybody to talk about realistic issues with the patient, and then take a decision of when you will deliver. So now, after we've understood this whole problem and we've understood that there's a recurrence risk to preeclampsia, there's a risk of cardiovascular disease. Dr. Mohit, is there a need to revise our clinical definition and management of preeclampsia? Do you think after all this discussion, you need to just revisit preeclampsia altogether and redefine it?
Get out of the term early and
Yeah.
late.
We have to see how practically it becomes possible, because if we are following up the patient all throughout, if the patient comes to you at the right time, maybe you can work her up, you can follow it up, you know what is happening physiologically. But then I don't know how this would actually work out in practice when patient land up to you directly in the second trimester, in the third trimester. I if I think obstetricians can better answer this.
No,
Yeah,
this sounds
so
very good in theory, but in practice, I think it's early and late.
exactly, you nailed it.
Yeah, this
Because
sounds
when
excellent
we
as a workup,
absolutely. So
not
when we are
possible.
talking about our everyday problems with preeclampsia, the fact is we have to deal with blood pressure, we have to deal with history, we have to deal with our regular screening, and we have to deal with the problem at hand. So whether the placenta is the cause of the problem or the victim of the problem, our final common pathway is managing preeclampsia in a way to achieve the best maternal and the fetal outcome. And we already heard about new methods of prediction of these problems, like the ophthalmic artery Doppler, which sir had done very nicely. Although, sir, people still wear makeup on the eyes also, and you may have to remove that also while doing that. But that's just a moot point. And prevention of, the placental problems like fetal growth restriction. And again, you have reasons to believe that the same aspirin is going to reduce the risk of fetal growth restriction, because it is going to reduce the poor placentation. So the prediction and prevention of preeclampsia becomes important, which we have already talked about in various ways. And as you go through literature, there will be different ways how the information will be given to us, whether from the fetal management point of view or the maternal management point of view. But when you put that all together, I think this year's theme is predict, prevent, and prevail. So if you do good screening, you will be able to predict preeclampsia correctly. Once you are able to predict things, you can do the right intervention at the right time and either prevent the onset of preeclampsia. For example, early onset preeclampsia may be prevented altogether, or prevent the complications of preeclampsia, which we just learned about how at every level some intervention is possible. So even if she's admitted with severe preeclampsia, you can prevent the next catastrophe. So prevention is again a continuum in preeclampsia. It's not just about preventing preeclampsia, it's about preventing all the effects of preeclampsia that come from there on. And prevail, because at the end of the day, when it says pregnancy induced hypertension, we are only talking about hypertension of the patient. At some point, the definition is also going to include the hypertension of the obstetrician and the fetal medicine specialist there, because preeclampsia does cause a lot of hypertension on the other side of the table as well, which is grossly under addressed. And therefore, after the whole management of preeclampsia, we all will have to learn to prevail. So before we go home, we have to take home certain messages. So I'm going to start with Dr. Nimmi. What is your take home message for all our people here?
So, because we are talking about theme, as you mentioned, is prevention. So, screening is very, very important. So all the pregnant women, at least they should be offered screening. Let the patient decide whether they want to go for the screening or not, but at least we can
Offer
tell them that-
screening to everybody for preeclampsia. Excellent. Dr. Shweta. Dr. Shweta? Can I take Dr. Vandana in the meantime?
So I would think that whoever is screen positive for preeclampsia, aspirin should not be at a lower dose of 75 or 81, which is given. It has to be 150, at least more than 100 milligram. So 150 to be started when the screen is positive, especially if uterine arteries are high, and continue till 36 weeks, not the previous one at 34 weeks. And start
So
as soon as the
do screening for everybody. And then Shweta, are you back? Not able to unmute her. Dr. Aparna?
Yeah, I would stick to the prevail part. So I would say that we must prevail at prediction,
Every
we must
stage.
prevail at prevention, prevail at thinking about preeclampsia at all times in the preconception and
times.
pregnancy.
Dr. Sita?
Yeah, I think we need to come back to our basics as well, and measure the blood pressure properly, starting out from in the OPD clinics, and make sure that is done properly, because that itself will have an implication on your screening, on your results of screening and everything. So make sure that is done properly as well, and train your nurses properly. So
Gujral, madam?
Well, the panelists have said it all. I would go a step further. For me, it should be a preconception. We get a lot of girls who come for a preconception check. And that's the point where I'll find out how much is going to be her risk of hypertensive disorders in pregnancy. Let's say BMI is more, she's insulin resistant. I like to put her on metformin because I have the data to say metformin, they'll have a 25-30% chances of lesser chance of preeclampsia. So her metabolic profile is very important. Her BMI is very important. Her addictions to me are very important. All these things, I optimize her if she comes to me preconception. Then as the conception comes, the BP, etc., everything we have all said, all that, And to me, it always, I've been wondering if any one of us has used prevastatin, which so much written work is there, that, if you have a delayed metabolic profile and you start them, the fetal dose is so low, you can give them in pregnancy. Personally, I've never used it beyond metformin. So I don't know if
There are a lot of
anyone...
medications about which a lot of research has
Yeah,
been
there
published,
are
but we
papers,
still
but
haven't used them.
at least I
And
have
at
not.
this
I've read
moment, I
about
think,
it,
correct.
But I
So
just
let's stick to what are the
whatever we use. Metformin and
understood,
aspirin.
because
Yeah,
we already have so much
metformin, I would,
confusion.
yeah,
We
correct.
need to minimize
So,
the confusion in our messages.
a preconception.
And absolutely.
Then of course, universal first trimester screening, absolutely.
Screening. Perfect.
With the IGF,
And
I would
Dr.
like to do
Shweta,
that.
do we have you? Dr. Shweta? I don't know, something is gone
Wrong,
with her phone. But she did give us a lot of input in our discussions earlier. Dr. Vandana, have you given your message?
Yes, I've given.
You gave that aspirin message.
I
And
just
Dr.
want to add
Mohit,
one more, if I
yeah.
have that don't forget her postnatally. Please follow her.
Yes,
of
you took
course.
away my point. I was going to say that because
Sorry.
as perinatology committee chair, that's something which I'm really banging on everyone, that, the fourth trimester, like Sir also alluded to, is something which we are forgetting. And everybody who has preeclampsia in pregnancy is at higher risk of having cardiovascular dysfunction later. And therefore, this has to be used as the window for the NCD development. And these are the women who have to be alerted that, you need to come for regular checkups and prevent cardiovascular dysfunction later on.
Annual
So,
checks.
yeah. Dr. Mohit, one word from you and then we wrap up. Your
Exercise. We have to emphasize the 11 to 14 weeks window. I mean, it's very easy to allot one staff to measure the blood pressure and to convince the patient to give a placental growth factor. Now, the problem with placental growth factor, as I said, is if the patient has had a previous history, then even if she's poor, she will want to spend that amount on PLGF because she doesn't want to go through that again. So I think counseling should help here to get these patients onto PLGF.
absolutely. And I think we all have to stop being so apologetic about costs, because, the cost of screening is offset by the cost of the disease.
Absolutely. And they're willing to pay. They're willing to pay once they've faced it in the previous pregnancy. Plus, uterine artery PI is something that I would like to emphasize upon. Sometimes it is technically difficult. Sometimes you have a very high resistance artery, difficult to visualize. You could have a abnormal course. So you have to be persistent and always follow the protocols. Everyone has to be on the same page to make the screening program work. See, very often you've seen this double markers failing because some people just do the NT, they don't want to spend on dual markers, and the screening programs fail. If you want an effective program, I think each one of us should utilize that 11 to 14 weeks window and do everything that is possible to predict preeclampsia.
Thank you. And we have Dr. Shweta, I think now. Dr. Shweta?
Yeah, thank you. So I
Huh.
think take-home message from me would be that to prevent, we have discussed a lot about aspirin, correct? Dose should be given. Two things we have not discussed is addition of additional calcium. I think between 1 to 2 gram additional, depending on the dietary intake, needs to be given. And third is exercise. If there is no very strong contraindication, suppose somebody with pulmonary edema and all, we don't advise, but OPD basis, ambulatory patients, then mild preeclampsia, then they should also be exercising, 30 to 40 minutes, at least some normal brisk walking. So these are three things we have in our armamentarium for prevention: aspirin, calcium, exercise.
So I think we really had an excellent discussion, and thank you all our experts for your brilliant inputs. Many of the messages were very clear, and I think there's very little for me to say now. I think I'm going to ask Khurana sir to wrap it up for us because he really does that very well. I'm looking at a few questions in the chat box if there's anything to say. Sir, all over.
Thank you, Chinmay. I think we've said a lot, but I don't want to go and end this program without without going into the details of the questions that are in the chat box. I think if
We
the
should,
panelists have a little more time, if they can stay on and answer the questions, and before we shut the panel itself, whoever one of us has spoken on that, Bimal Sani can take over and go through the questions in the chat box. But otherwise, it's been one of the most
Yes, sir.
marvelous.
No, sir. Bimal, sir, I'll just read out the question for you and you can help us answer that. So this is Dr. Anupama Hudge who's asked, can anybody tell in detail about which BP apparatus to be used for mean arterial pressure and where we'll get it?
Chinmay, let's do the other way around. Bimal will read out the questions and the panel can
Okay.
answer them.
Yeah, we can do that. Yeah.
Yeah, since you've already asked that, which BP apparatus?
So,
Anyone who wants to answer from, or sir, you can tell us.
there is one brand, which is a Vietnamese brand, which Kypros Nicolaitis talks about. But the fact is that we will always use an aneroid one, and there are several local brands that are very good. And the best thing is to make sure that you calibrate your particular machine against a standard machine every now and then. But a lot of our ICUs now use several other brands, and they're pretty good. But the Vietnamese one is the only one that's approved by FMF. I don't know whether we should stick to that or not. Omron is the one. I use Omron just from a medical legal point of view, but there are several good Indian brands as well.
Thank you, sir.
Yeah.
In the first trimester, it should be yeah. Then we have what is the turnaround time for SFLT PLGF ratio?
Dr. Nimmi.
So in our lab, it's alternate day we are doing, but many labs are reporting daily also.
We get the report in 124 hours.
Yeah, 24 hours.
Yes.
Okay. First trimester screen negative, second trimester screen positive for preeclampsia. Is it possible?
Yes, it is possible because there are two different methods. First trimester screening is for prediction and the second is for prognostication. So it can be that you have a second trimester which comes out as positive.
But you don't start aspirin. It is for basically surveillance and not prevention.
One more question, that if the patient is already on aspirin, do we still have to monitor in the third trimester with uterine artery Doppler? we can cross-check with Doppler improvement? In the sense, if she's already been started on aspirin, then do you still want to keep doing uterine artery Doppler?
I think it's important for us to know why we are doing the Dopplers in the first place. So in the third trimester, for the role of doing a uterine artery Doppler would be to corroborate the growth pattern of the baby. And if we want to define a growth restriction at that point. But if she's already on echosprin, just looking at the Doppler is not going to give us much information regarding her stage of preeclampsia. That is what we discussed at that time. Where Dr. Aparna, do you agree with this? That when she's already on echosprin and other factors for preeclampsia are being considered, at that point, do we look at uterine artery Doppler as a factor to define preeclampsia?
Oh, you won't. I mean, it's not going to help you define preeclampsia, diagnose preeclampsia. But what is important at this stage is that if she's at high risk for preeclampsia, you will be monitoring her for development of preeclampsia. Like we saw, aspirin reduces the risk of preeclampsia by 80% and 60%. So a person who's at high risk of developing preeclampsia would still be at risk of preeclampsia in the third trimester. So we need to be on our toes for surveillance. So that is what is important. So if the uterine artery Doppler is high, you keep monitoring the blood pressure, which you would anyways monitor. But where are you going to deliver? Where is the patient going to be? That is something that needs to be seen.
Okay, thank you. Is there any role of maternal echocardiography in the routine antenatal care of identified preeclampsia patients? Do you suggest echo for the mother?
We are doing a thesis.
In some states, like in Tamil Nadu, it is a routine practice to do a maternal echocardiography in the second half of pregnancy. Now, this has been started as a government policy in Tamil Nadu, and every woman who's pregnant gets the opportunity to have a fetal echo. And in their situation, they have said that it has
No. It is maternal echocardiography.
Yes, sir. Maternal echocardiography.
Yeah.
In Tamil Nadu, every pregnant woman has an echocardiography herself. And based on these findings, they have proven that it has improved their, outcomes in terms of peripartum cardiomyopathy and maternal cardiovascular dysfunction in pregnancy. This is a role model which they have set because of, their data on maternal mortality. We still have not been able to replicate it all over the country. The decision of whether everyone who has preeclampsia should have an echocardiography will depend on the hypertension status of the mother at that point. And I think if the institution is able to provide an echocardiography, it's a good idea to do it, because it will just absolve you of the situation that you are dealing with some definite cardiovascular dysfunction, because we are saying that this is going to lead to long-term problems. So it's a good idea to do it. Again, whether it's a chronic hypertension superimposed on preeclampsia, you can see the echo changes and comment on that also. So given a opportunity, if it is possible, please do it.
Yes.
If history suggests moderate to high risk, but uterine artery is Doppler in the first trimester, can we still start her on aspirin? Can we empirically start her on aspirin?
Dr. Aparna?
Yeah, so actually I had raised my hand for the previous question, sir. Can I just quickly answer that question?
Yeah, sure.
So actually, thing is that, preeclampsia, the hypothesis now is that there are two different types of preeclampsia. The early onset is more placental, the late onset is more cardiovascular. So there is an increasing role of doing a maternal echocardiogram, especially when it's a late onset preeclampsia. So now increasingly as a protocol, we are trying to incorporate that, but there is still more evidence that needs to be generated if we want to incorporate that. But as Dr. Jinmay said, there are pockets where there is being done. But I think in 1 year's time or little more time, we'll be able to come back with a more definitive answer. Now, regarding this particular thing, I think everybody would agree when we say that the point of multimodality screening is to decrease the false positive rate and putting actually everybody on aspirin. If you just do a history-based screening, you would be putting around 40% of your population on aspirin. While if you incorporate all of your screening parameters, you would actually be putting 10% of the population on aspirin while achieving the same detection rate. That is the purpose of incorporating all the parameters.
Thank you. Rest of all the messages are all appreciation for the lecture by Dr. Shukrana and the panel and the answers by the panelists. Wonderful.
Thank
I
you
think
Bimal,
very
for
informative.
moderating that. Yeah, thank you, Ben, for moderating that. So, as Chinmay asked me to wind up, there's one question that remains unanswered in the minds of a lot of people tonight, and that is, what is the cost of SFLT PLGF? Well, someone has to pay the cost, either the government or the taxpayer or the individual who's paying out of his own pocket. The cost currently with most labs is about 3,200 rupees. If you compare the cost of 3,200 rupees, even with the cost of routine, high dependency unit care and NICU, it is really a big zero compared to the amount of investment that is going in. If you compare it to the cost of the value of the life of a woman, it is absolutely nothing. So we have to stop thinking in the paradigm that we've been thinking of, and that is that it is expensive. It is not expensive. It's being penny wise and pound foolish to not do this. We do understand that in cities like Delhi, the price is constantly coming down and our turnaround time is really the same day. So if I send a sample in the morning, I am for almost half that cost getting an answer by 3:30 p.m. in the afternoon. And this is something that has started happening on a regular basis. We have to bargain with the companies on this. And just like we've driven home all the rest of the messages, and I really thank the panel for having made such a practical thing out of it. Chinmay, thank you for leading this, and for the panelists for being so enthusiastic with their support. We must understand that the price is the bottom line we've been talking about, and that price is nothing compared to the price of the life of a woman. And let's remember that, especially for preeclampsia, which is one of our biggest killers. Let's not forget that we need to follow her up. As far as maternal echocardiography is concerned, we know that it is not something to be done randomly as, oh, this heart is contracting fine. No, we must assess diastolic dysfunction. We must assess systolic dysfunction. It has to be done by a proper protocol, by a person who's familiar with doing this. We do understand that the pregnant girl has a body physique that is very, very unfriendly for maternal echocardiography. And it's especially so in Northern India with a huge amount of subcutaneous obesity. And it's not the easiest of exercises, but it's something that we need to consider, because that is the only thing that's going to save her from dying of some terrible diseases between the ages of 38 and 52, when it's not that we need her the most, no, we need her all the time, but really something useful for her general health future. So with that, thanks ever so much. Rima has been the backbone of this entire program, and she's been keeping very quiet. Thank you, Rima, for being there always. And in spite of her little recent stint in Barcelona for a course, she's been able to organize this very beautifully. Thank you, Chinmay, for the panel discussion. Thank you, Mohit, for your introduction and for your participation. And Bimal, thank you so much for all that wonderful question and answer session. Each of the panelists, you were absolutely marvelous. And I think when we incorporate the laboratory as well as the clinician, we're going to be able to serve our persons well. Let's take this forward. Let's try and develop some protocols for ourselves, which would be specific. And I think we need to go beyond the fact that women in developing countries don't deserve appropriate screening. We must, well, it doesn't seem correct to decry that thing, but it really seems appropriate to say we have to go beyond that, rise above that recommendation, and ensure that the bureaucracy does not misunderstand us, and that first trimester screening should be made routine in the years to come, and very soon. Thank you very much for being here tonight. And thank you, panelists, for being there. Thank you, delegates, for being here. And my thanks to the entire organizing committee for tonight for putting this together. Thank you and good night.
Thank you.
Good night.
Good night.
Thank you, everyone.